السلام عليكم ورحمة الله وبركاته، والصلاة والسلام على سيدنا وحبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. إن شاء الله اليوم هنتكلم عن موضوع البوليوما فيروس البي كي فيروس مانجمنت مونيتورنج تريتمنت افتر كيدني ترانسبلانت. نتوكل على الله عشان التايم. طبعا ده الاوفر فيو اللي ممكن هنتكلموا عنه، التريكات دي كلها اليوم ان شاء الله نحاول نغطي النقاط دي كلها باذن الله. You can read now and just a hint before we starting, just what is risk factor for PK virus, especially increase after tacrolimus with high dose of tacrolimus because intense more than cyclosporin. Some patient now in the clinic, we are shifting from tacrolimus to cyclosporin because cyclosporin a little bit less potent than tacrolimus. And also acute rejection is another risk factor because heavy immunosuppression will used for treat this, as we discussed before. Male already high risk than female, and age elderly more. Delayed growth function, it's more also a risk factor for this one. Previous transplant, another risk factor. Cadaveric also another risk factor, not like live donor. Ureteric stent, all this will be risk factor for BK virus nephropathy. And I just enumerate all risk factor in this slide also from donor factors and recipient factors, all this mentioned here, same, and the transplant factor, tacrolimus, ATG also is the one risk factor, rejection, ureteric stent, ABO compatible transplantation, or risk factor you can read, you will find in this slide for BK virus nephropathy. Unfortunately, no vaccine or effective antiviral are currently till now available for clinical use. No vaccines, no antiviral till now. What is the BK virus? is a human polyomavirus latent in most adults. موجود في معظم يعني موجود في معظم البشر عموما، يعني latent, only reactivated under immunosuppression situation. What is the significant in transplantation? Can lead to BK viruria and viremia and nephropathy and the potential graft loss either by direct effect from the virus or from indirect effect by decreased immunosuppression. And this, what is the definition for polyoma nephropathy or BK virus nephropathy? Either possible BK virus nephropathy undetected in plasma by BK virus D anemia. If the BK virus DNA urea more than 10 million copies with urine or urine cell decoy cells or tissue as electron microscopy to detect polyoma virus. If any positive plasma PCR, all this possible BK virus nephropathy. Probable BK virus nephropathy with DNA viremia in the plasma more than 1,000 twice measurement 2 weeks apart, and continue monitoring. Just will continue monitoring every 2 weeks. It will increase or no, or just will stabilize around 1,000, and will come to that when to treat and when not to treat. This is possible if you will find one of this, and this probable if you find one of this, and this presumptive BK virus nephropathy. If plasma BK virus D anemia more than 10,000, no way. This should be treated. If more than 10,000 copies per ml, this should be treated. This presumptive يعني مؤكد إنه هو عنده BK virus nephropathy. But if more than 10,000, and you should start treatment for this one. Biopsy in case of graft dysfunction or surveillance should be to confirm the diagnosis. To confirm this diagnosis, because sometimes it will be refractory to the initial treatment, and sometimes some patient need IVIG. Now this is different definition of BK virus, and will come when to treatment. This is according by Dr. Cotton et al. Transplant 2024. How frequent are BK viruria or anemia, either in urine or blood? How frequent? First year post-transplant, we have high level BK virus in urine, DNA in urine, around 20 to 40% of the recipient, and in blood, around 10 to 20% of the recipient. Biopsy proven around 8% from 1 to 15, but this 8%. This is a frequent of the BK virus in blood or urine. And latent onset BK virus, the anemia in the blood, second year post-transplant, around 10 to 20% of the recipient, and 3 to 5 years post, around 1 to 10%. This is the frequency of either BK virus in urine or blood, first year and late onset after the second year. First year in urine 20 to 40%, on the blood 10 to 20%, and in biopsy around 8% from 1 to 15%. Second year around 10 to 20% in the blood, and 3 to 4 years 1 to 10%. BK virus monitoring protocol. This is the protocol we are using now, just monthly for 9 months post-transplant. Post-transplant PK PCR in blood, plasma PCR. Monthly for 9 months post-transplant, then every 3 months until 2 years post-transplant. And this screening to detect BK virus nephropathy. The protocol DNA, BK virus DNA, quantitative PCR monthly until 9 months, as we mentioned. Then after that, every 3 months for 2 years. And this is different from pediatric or combined organ transplant until 36 months. In intensified immunosuppression, received treatment for rejection, maybe resume monthly screening for another 3 months after each rejection or intense immunosuppression. Kidney biopsy in case of graft dysfunction or surveillance, for especially within this bone marrow, whatever. For non-kidney transplant or solid organ transplant, only if presenting with declining renal function, no other reason for renal compromise. And lab testing, consider the same, just keep in your mind, just keep same sample, don't do, and same lab, same technique, same steps, whatever. Don't change from lab to lab, because it will give you the different result already. And when to consider treatment? Treatment should be considered of PK plasma PCR more than 1,000, but less than 10,000, and the next testing increasing. لما تلاقي الليفل بتاعك more than 1000 or equal 1000 with increasing frequent monitoring, or but less than 10,000. But if you're repeating the test, you will find between 1000 to 10,000. But if you repeat, you will find increasing, and you should start treatment. And you should treat if more than 10,000. Don't wait. You should treat. You should start the treatment from 1000 to less than 10,000, just monitoring, treat if it's next test increasing by 1 log by 1,000. And from BK virus plasma PCR more than 10,000, don't wait. You should treat already. You should start the treatment for that. And in factor influencing treatment decision, already we have ايه العوامل اللي بتأثر معاك على التريتمنت decision. Degree of the viremia and renal function already, and biopsy finding. The moment I put the charger. يبقى factor affecting the treatment decision, degree of the viremia now more than 10,000, you should start the treatment, or 1,000 to 10,000 as we mentioned, and increasing with frequent monitoring. Usually they are doing every 2 weeks. If the increasing viremia, you should treat, and renal function, if it's deteriorated, you should treat. Biopsy finding, if just revealed BK nephropathy, you should treat. Treatment is case by case. This depends on each case is different from others, since each center hospital protocol is different. Mainstay of treatment. What is the main column or main key point on treatment of BK virus nephropathy? The first thing, just a reduction immunosuppression is the primary approach everywhere. Every recommendation, just reduction immunosuppression. Subsequent steps, just adjust monthly based on the BK PCR result. Reduce or hold antimetabolite. Will start by mycophenolate mofetil or azathioprine. Lower calcineurin dose after this. If no response for this, you should go ahead and lower CNI dose. Tacrolimus level reduction. Sometimes we are making just target level around 5, or sometimes 3 to 5 if aggressive BK virus nephropathy. Consider switching CNI to M2 or sirolimus, because the intensity of immunosuppression lower. Use with caution, guided by in our transplant clinic team. Follow-up and monitoring monthly BK PCR testing during the treatment. They do some center doing every 2 weeks, some doing every month according to the resource. assess renal function regularly, should close monitoring, repeat biopsy if renal function decline or no improvement. Goals of therapy: prevent progression of BK virus nephropathy and preserve your graft function and make balance between infection and rejection. This is a goal of therapy with BK virus nephropathy. ما فيش حد بيحب البي كي فيروس post transplant، but ده الايم of therapy بتاعك to prevent progression, prevent graft loss and make balance between infection and rejection. Early detection and monitoring are critical. Treatment is guided by viremia level and the clinical context. Immunosuppression reduction is the cornerstone of the management. And this, you should take a screenshot and keep in your clinic if you are following transplant patient. If your viral load less than 1,000, just continue monitoring every 4 weeks. Because you are doing screening here and you found viral load less than 1,000, just continue monitoring every 4 weeks. If you are screening 1,000 to 10,000, repeat within 2 to 4 weeks. I think 2 weeks is fair for your patient. 1,000 to 10,000, just repeat viral load in 2 weeks. And if your viral load more than 10,000, you start to reduce your MMF by 50% and keep your target list around 5 to 6, 5 to 7. And repeat viral load in 4 weeks. If still more than 10,000, reduce more or held MMF and repeat in 4 weeks. Persist more than 10 weeks, consider IVIG for resistance cases, plus or minus conversion to cyclosporin. This is another protocol to convert tacrolimus to cyclosporin because less intensity المناعة بتاعته، يعني قوة المناعة بتاعت التاكروليماس أقوى بكتير من السايكلوسبورين. Our target level less than 4 to 6 for tacrolimus if you like to keep tacrolimus dose. If your viral load here from 1,000 to 10,000, just start to reduce just by monitoring of this 1,000. If start to increase, just start to decrease MMF by 25 to 50% and continue viral load screening every 2 to 4 weeks. And we mentioned viral load less 10,000 continue monitoring reduce MMF further until لو لسه يعني لغاية ما تقل من أقل من 1000. After أقل من 1000 you can start just resuming, not resuming, just keep low dose of MMF until we reach undetectable viral load. You can resume the dose after that gradually by smaller doses. Monitor until viral load negative for 3 consecutive months, and after that, this depends on your patient sensitization, CPRA, and HLM mismatching. You can start just resume small doses and close monitoring. If any recurrence, just keep small dose or just continue hold myfortic after. For another therapy, as we mentioned, IVIG, when to consider IVIG in treating on viral BK virus nephropathy or polyomavirus, high BK viral load, resistance to the previous management, biopsy proving or suspected BK virus nephropathy should go ahead by IVIG, and failure of other immunosuppression reduction to control the viremia. Usually we are given 200 milligram per kg 200 milligram per kg weekly for 5 doses. Total dose, cumulative dose 1 gram per kg. And some centers, sometimes if aggressive, you can give 2 gram per kg. Additional doses may be considered based on the clinical response for your patient. And we have discussed IVIG mechanism of action before in the previous lectures. Note, IVIG is an additive adjunct treatment, not first line, used in collaboration with transplant team. Third line or alternative therapy, if your patient is still with deteriorated graft function and no response to other medication, we have leflunomide and cidofovir. Our switch to cyclosporin to immatures. If you switch from tacrolimus to cyclosporin, then you can switch cyclosporin to immature like sirolimus. These are considered the third line option used when the first line immunosuppression and the IVIG fail and no response. But commonly we are using leflunomide, and I think the dose is 20 milligram. I discussed this before in our previous BK virus talk remotely 2 years back. And individualized immunosuppression management, rate and extent immunosuppression reduction be individualized, and consider rejection risk while you are decreasing immunosuppression, just monitoring your DSC and kidney function response to the prior reduction. Immunosuppression should not be stopped completely, expert opinion, just to decrease the dose and the monitoring. monitoring schedule creatinine every 2 to 4 weeks, and de novo DSA or donor specific antibodies at 1 and 3 months at least. If there is unexplained graft dysfunction or DSA, renal ultrasound, allograft biopsy to be sure you are not missing any post-renal or rejection. Reintroduction immunosuppression when BK virus undetectable for 3 months. Once undetectable for 3 months, you can reintroduce just 50% of the prior MMF dose and continue monthly BK PCR monitoring for 3 months after resuming MMF. Chronic BK viremia or retransplantation. Some patients may have persistent high viral load. Long-term management may be needed. Graft failure. Also, BK viral load must be undetectable before retransplant, and the graft nephrectomy is not required. Just will wait and screen and try to decrease your immunosuppression to keep your BK viral load undetectable before retransplant. And this just summarizes the immunosuppression reduction by general approach and strategy 1 and strategy 2. General approach just confirm that all immunosuppressive drug doses and the concentration are within target, especially tacrolimus and MMF. You can request the level for both. Monitor BK virus DNA by the same plasma level or all blood according to your lab every 2 to 4 weeks until clearance or stabilization at less than 1,000 copies per ml. If already on minimal immunosuppression and has anemia less than 1,000 copies per ml, follows the viral load and the serum creatinine every 3 months. Strategy 1, reduce antimetabolized dose by more than 50%, no further immunosuppression reduction. If one log drop at 4 weeks, otherwise discontinue antimetabolites and taper steroid to 5 to 10 milligram a day. Add prednisone 5 to 10 milligram a day if not on steroid to avoid CNI monotherapy. If needed, stepwise reduce the tacrolimus target trough around 5 nanogram per ml or cyclosporin trough around 100 nanogram per ml. Strategy 2, reduce the CNI by 25 to 50% in 2 steps. If reduce tacrolimus target trough to 3 to 5 nanogram per ml. If reduced cyclosporin target to 75 to 125 nanogram per ml. No further immunosuppression reduction if one log drop at 4 weeks. Otherwise, reduce antimetabolized dose by 50%, taper prednisone to 5 to 10 milligram a day, and discontinue to metabolize, add prednisone 5 to 10 milligram if the patient not on steroid to avoid CNI monotherapy. And I would like you to take a photo for this one and keep in your clinic, on your notes, in your WhatsApp, just to how to manage and how to treat any patient with BK virus nephropathy post-transplant. This is the last guidelines by Dr. Cotton et al., I think 2024. You can follow this, and I hope you will have got a clear approach for immunosuppression reduction for treatment of BK virus nephropathy. And this Dr. Cotton, the second international guidelines for management of BK virus nephropathy 2024. I hope if you have any question or concern, just text me or just comment on the videos. And if you like any more videos on any important topic facing in your clinical practice daily, just put in the comment of this video or other videos. ولا تنسونا من صالح الدعاء ولا تنسوا الصلاة والسلام على حبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. والسلام عليكم ورحمة الله وبركاته.